Hello. It's a pleasure to talk to you all today. So I'm going to talk to you about pain in EDS and in its relation to dislocations. So if I'm going to talk to you about pain, I need to talk to you about what it is and how you experience it. It sounds crazy to ask you, what is pain? You would have thought it's blinking obvious, isn't it? But actually, it's more complex than that. And one way of looking at it is everyone here will have experienced acute pain. That's when we have an injury, that's the pain we feel. And our medications are usually pretty good at treating acute pain. What we struggle with is chronic pain, and that's where the pain keeps going. And I know that a lot of people in this room will also have the chronic pain. And the difference there is our medications don't work as well. So, acute pain. This is the pain that happens when we have an injury and when we have damage. The injury and the damage makes pain receptors fire. They activate our pain nerves, and that goes to our spinal cord. The spinal cord transmits those signals to our brain, and we experience pain. Ow! That's pain. That's acute pain. Pain will then switch on behavioral and emotional responses. Because it has to. We have to protect ourselves from pain. It switches on our fight and flight responses. Some of you may have heard of that. And that switches on our autonomic system as well, which you will have heard about this morning. And after the pain and the injury, as healing, it's followed by this rest and repair phase. So why is pain so important, and why is it so hard to treat? And that's because pain is an evolutionary protective signal. If you go back to being a caveman or to being a rabbit or an animal, if you have pain, it means danger, there's damage. Stop using the bit that's injured. And when you stop using it, it has a chance to repair. And once it's repaired, the pain switches off and we go back to using it again. But in chronic pain, that switch off does not happen. Now you have pain signals all the time. So your brain and your spinal cord and your pain nerves are transmitting pain all the time. Now, pain is no longer about damage. Pain is about a confused pain system. So what pain mechanisms do we experience in hypermobility? Well, there will be what we call biomechanical pain. So this is pain that you get with subluxations, with dislocations. This will be acute pain. There may be ligament pain from injuries, tendon injuries. Some people might get early wear and tear arthritis. And a lot of people in this room, I'm sure a show of hands, how many people are really clumsy and tend to fall over a lot? Yeah, lots of hands. So you're going to get more injuries. And then there will be the muscle pain, what we call the musculoskeletal pain. And the muscles in hypermobility are often very irritable, and a lot of people complain of spasms in the muscle. And muscles often, because they're painful, we don't use them, so they get weaker, and they get what we call deconditioned. And then some people overuse some joints and overuse other muscles, and that causes pain. For some people, because we're more bendy, we can get nerve pain and nerve injury. And while some people get chronic pain, which is there all the time, not everybody does, and we still don't understand why. So what happens to make pain become all the time? Well, one of the things that we talk about is something called peripheral sensitization. And that, in its simplest, means that the pain nerves are firing more easily and more often. So now there's a lot of pain information coming into the spinal cord, and that's what we call peripheral sensitization. Now, central sensitization is similar, but that's where pain in the spine and in the brain is switching on and is more irritable and is firing more often. So it's winding up that whole pain system, and that's what we term central sensitization. But the brain is very clever. If in evolution you just had pain and it overwhelmed you and you were just paralyzed, you'd be eaten. and that's not very good in terms of survival. So the brain can actually make pain tune it up and make it higher, and it can also tune it down and make it less. And this is what we call descending control. And this is a relatively new concept in neuroscience. And we know that it's coordinated in what we call brainstem centers. And some of these systems are inhibitory, so they can actually tune pain down, and others are facilitatory, so they actually tune pain up. And we know in some chronic pain syndromes and some pain conditions, this descending control is faulty. It's not working as well as it should. So why, this is a slide behind, so this is the descending control. So again, why is pain so important to us? It's because it's this evolutionary protective signal. If you have pain, in evolution, you would run away or you fight it. That means it has to switch on your emotion. It's what it's for. So it switches on anger, rage if you're going to have to fight, or panic and terror if you're going to run away and flee. So pain has to switch on your stress centers, and it has to switch on your emotional centers. And neuroscience shows very strong links between this. So pain has to link to stress centers. So I hope I've given you an overview of how pain itself can change how pain works. Pain can wind itself up so that you get more pain with less and less provocation. And when it becomes like this, that pain itself is changing how pain's worked, the whole system is wound up, it's what we call centralized pain. Now, we think this is why pain syndromes often overlap with each other. I'm sure there are lots of people in this room who, as well as having hypermobility or an EDS and musculoskeletal pain, may also have diagnosis of fibromyalgia, of irritable bowel syndrome, of chronic fatigue, of temporomandibular joint dysfunction, of pelvic pain, and I could go on and on and on. Pain syndromes usually overlap with each other because what they have in common is this wound-up pain system. So what about the brain? It's one of my fascinations. And this is why I put it up, because this is what we often forget. Pain is both a sensation and a perception. And I've illustrated that with these slides. So normally, pain is painful. We don't argue. But these two pictures on the left are taken from a festival in Thailand and in Malaysia, where people deliberately put things into themselves. So they skewer themselves with swords, with great big rods, and yet apparently they do not experience pain. And many are experiencing pleasure because they're taking part in the ceremony. And that slightly jokey slide at the bottom there, in a sadomasochistic parlor, that would be pleasure. But in Guantanamo Bay, that is torture. But all of these pictures have in common, your pain system is firing. It's the same mechanisms, yet how we perceive it and our response to it is completely different. So I'm asked to talk about pain and managing it, so what about medication? Well, for acute pain, this is the sort of trauma pain, injuries, subluxations, dislocations, that gets treated much the same as for someone who doesn't have EDS, because as we've seen, acute pain, we're better at dealing with. So in an acute injury, a sprain or a subluxation, you would treat it with rest. You might use cold if it's hot and swollen. If it's swollen, you might need to elevate it a little bit, and sometimes a light bandage, a little gentle compression may help. You would use your normal pain-killing medications to help with that pain, but the important bit is to avoid having that injured limb immobilized for too long. For a short time, to support the joint, yes, a splint can be helpful, but a splint welded onto that joint for weeks and weeks is bad, because you will weaken that joint and you will weaken the muscles, and that makes the instability worse. So careful use of splints. Chronic pain is much, much more difficult. And my main advice here is keep it simple. I see too many people who have been given medications That causes side effects, so they get a tablet for the side effect, which causes side effects. They get a tablet for the side effects, and before you know it, I've got someone on 20, 30, 40 medications, and I kid you not. So the main advice is keep it simple. My other advice is for some people, generally we advise do not use high-strength morphine medications if at all possible. There will be some people who do need high-strength morphine, but it should be in low doses. In high doses, it causes so many problems. EDS is a condition that already upsets the gut, it upsets the autonomic system, it upsets the blood pressure. It makes your memory bad because pain is grabbing attention all the time, and then I give you a drug that makes all of that worse. So morphine needs to be approached with extreme care. And when I have a patient who I'm seeing for the first time, my advice is don't let anyone put you on morphine if at all possible. Yes, some people do need a low dose, and usually if you're on morphine, quite often it needs careful surveillance and support from the primary care doctor and sometimes from pain clinics. We tend to use a lot more of what we call neuromodulatory medication. So many people here may be familiar with medication like amitriptyline. It's an antidepressant, but in small doses it helps to damp down pain nerve firing. Gabapentin and pregabalin, these are anti-epileptic medications. So again, they damp down nerve firing. Duloxetine is another antidepressant. This one works on both noradrenaline and serotonin pathways, and those we know are involved in that descending control that we spoke about earlier. Muscle spasms, very, very hard to treat. Again, I see too many people being given high-dose diazepam long-term. That is not how it should be used. Diazepam is what we call a barbiturate. It's very high strength, it's very addictive, and quite often it makes your muscles too relaxed. And everyone here knows if you relax your already unstable joints even more, you're going to fall out of joint even more. So diazepam does sometimes get used in short doses for short periods of time for bad spasm, but it shouldn't be used in high doses long term. It's not what it was for. So in terms of medication, advice is above all, balance how much it helps against the problems it's causing. If it isn't helping or it's causing too many problems, stop it. Don't end up with an ever-increasing list. And just remember that unfortunately in this sort of pain, drugs don't work very well. That's not your fault, it's not my fault, it's fact. In chronic pain, our drugs are not that great. And the number one advice here is don't become a drug zombie. You will still have pain, but you won't care about it. If I give you all enough morphine, you won't care about it, you will still have the pain, but you won't be you either. And you won't be you around your family, and you won't be you around your friends. The other thing to mention is if you have pain all the time, 24 hours a day, 7 days a week, it's not surprising that you might have depression and anxiety. In fact, I would be astonished if you didn't. They are very common. It's not madness, it's not weakness, and I hope from what I've just shown you, you can understand why it's what pain does. It's designed to switch on stress and emotion centers. But if someone has bad anxiety and depression, it will continually feed into that pain cycle and make it worse. So sometimes, some people will need some counselling. They may need some medication if you have bad anxiety and depression. And if that allows you to get more control, use it. And don't be afraid to use it. So, mind and body. I hope what I've just explained to you is how important your brain and your body are working together. You can't separate your brain from your body. People who have chronic pain get depression and get anxiety. That feeds back into pain. We know there are higher rates of anxiety in hypermobility, and we know that there are higher rates of abuse and adverse childhood circumstances. That might be illness, it might be abuse, and that's much higher in chronic pain clinics. And that's probably because if you're experiencing a lot of chronic stress in childhood, your brain has to adapt. but in later life, those adaptations may be a problem if you have pain. It's something that's fairly new and we're still trying to understand. So the key important bit is your brain and your mind and how they work together. So why do doctors and patients so often think you can cut one off from the other? It always astonishes me. Why do we think you can just look at the brain and ignore the body? Or I can just look at the body and ignore the brain? Of course you can't. So in summary, with the pain side of things, we're better at working with the acute pain. The chronic pain is much more complex, as I've just shown you. Look at the individual person and try to understand what sorts of pain you're getting and why. Painkillers may help a bit, but they're not going to make it go completely. And actually, rehabilitation is much, much more important in this, and I know that you'll be hearing more about that. Remember about pain, stress, and emotion, and that for some people, psychology approaches will be helpful. And don't be afraid of the psychology and psychiatry. It's just another tool in the box trying to deal with this. So, I was also asked to talk to you a little bit about managing subluxations and dislocations, which I know will be very problematic for many people in this room. So that means I need to talk to you about pain and the muscles. Because they have extra movements, extra hypermobility in the joints, the muscle fitness and tone supporting those joints is really important. That is what helps to compensate for the extra bend in the joints and in the ligaments. But muscles, as we've mentioned, can often be very irritable. And if you get deconditioned, that irritability and that instability gets worse. And then on top of that, we often see something called muscle patterning, which can actually make subluxations and dislocations much, much worse. And I'm going to explain some more about that. So around a normal joint, muscles normally work together in a smooth and nice coordinated pattern. Some muscles switch on to make that joint move, others will switch off and relax to allow it to move. So normally these are cooperating together and they're not arguing with each other. But in muscle patterning, the muscles around the joint are arguing with each other. Some are overactive, they're on all the time. Other muscles are not switching off. That coordination has gone. You now have muscles arguing with each other. And this patterning can actually pull the joint out. And for those people that have recurrent dislocations, often in the shoulder, it's this muscle patterning that drives that. So in a subluxation and dislocation, there will be acute pain and there will be chronic pain. So you will get the both happening. Joints can come out easily, but just remember, provided those muscles relax, they will go in easily as well. It's the muscle spasm that will stop you from getting a joint back. And stress, panic, and anxiety make that muscle spasm much, much worse. And this becomes a vicious cycle. And what typically happens is if a joint is out, again, think of what we've discussed. If you have pain, it switches on stress centers, it switches on emotion centers. You will switch on your fight and flight pathway. That will cause more stress, which will cause more spasm in the muscle, which is pulling the joint out and keeping it out, which causes more pain, and it feeds into itself. And the more this feeds in, the less chance you will have of getting that joint back. You have noisy joints. Most people in this room will have noisy joints that clunk, that click, that snap, that pop, and you'll never creep up on anybody. They will hear you coming. But just remember, and when I see a patient early on, not every click, snap, and pop is a dislocation or a subluxation. Many aren't. A lot of them are muscles and tendons making noises. So for those patients, when I see them early, I'm educating them that actually it's okay to have noisy joints. That's normal for you. So the main key for subluxations and dislocations is to understand your joints and how to manage it yourself. so that you're not having to go to emergency rooms or to doctors who don't understand. Common joints, shoulders, hips, knees. It's actually worth mentioning that if you have hypermobile EDS and you have normal hip anatomy, it's very, very rare the hip dislocates. I've never seen one. That's not true if you have hip dysplasia where the anatomy is abnormal. That's something slightly different, but fortunately is very rare. More often, it's snapping and what we call snapping hip syndrome. And it's not a subtle snap. It sounds like a pistol shot. So in recurrent dislocations, really problematic joints that are coming in and out several times a day, and some people it's multiple times per day, it's the muscle patterning here that's the main cause, and surgery will not overcome that. And I think that's really important to say, particularly in the shoulder. I can understand why, if you have a joint that comes out, it would make sense. Can't you just tighten it up and keep it in? Well, not if it's the muscles pulling it out, you can't. So the main answer is to understand if this is contributing to the cause and to recognize it and treat it early. So you all need to develop, if you don't already have, a subluxation and a dislocation plan so that when this happens to you, you have a technique that you use to get it back. Usually, you don't require aggressive manipulation to get the joint back. If your partner is a big guy who's 80, 90 kilos and is trying to lever your hip back in with his full weight, you're doing something very wrong. Normally, it just needs a little bit of a wiggle and it'll go back. Learn what the cause was. If you've had a dislocation or a subluxation, had you done something? Had you lifted awkwardly? Had you not thought about what the position of your joint was before you did it? What was the trigger so that you can learn from that? And above all, frequent visits to the emergency room is definitely not the answer. Try to keep away from the emergency room as much as you can. I'm sure lots of people will understand that. So, what does a dislocation plan look like? Well, actually, it's pretty simple. It's not complicated. The first thing is, don't panic. Very easy for me to say, much, much harder for someone with a horrible joint that's out and is causing pain. But it's the number one thing. You're switching on your fight and flight pathway, that stress pathway. You have to be able to switch that off because this is going to make it a lot worse. Remember, it's horrible. It's horribly painful. It's frightening, but it isn't life-threatening. And normally, it is not something that causes severe damage. It's a pain in the backside, but it doesn't normally cause severe damage. If it's out, support it in a comfortable position. So you might need to get the pillows out, the cushions out. Get it in a comfortable position. Breathe normally. Slow your breathing down. Most people, if you have a subluxation or a dislocation, because of that stress, you're not taking normal breaths. You're taking shallow, fast breaths. Slow it down. If you've got your backup painkillers for bad times, this is the time to use it. Anything you can do that helps you to relax, do it. If it's heat, if it's massage, if it's music, if it's your partner singing you a song, it doesn't matter. Whatever helps to get you to relax, use it. Next thing, give it time. It doesn't have to go back in 5 to 10 minutes. If it takes an hour, 2 hours, 4 hours, it doesn't matter. Give it the time. And as soon as you've managed to get that relaxation that you need, use your normal technique to get it back. So that it might be that little wiggle, it might be that little bit of manipulation, just to get it back. And then once you've got it back, treat it as you would any other muscle injury, acute injury. So you might need to use that rest, that ice, that compression, that elevation. You might need to use your splint or support for the next few days, but don't have it on for weeks on end. I've seen too many people that have a kneecap dislocation, and have you seen those horrible, what we call cricket pad splints? Just holds your leg completely straight. I've seen people coming to me 4 months in one of those. That's just not what you want to be doing. So careful use of splints and supports. Now, I was trying to practice my Spanish, so apologies. A plan de dislocación will look like this. no te asustes, respirar normalmente y mantener la calma. I can do it in French as well, but I'll spare you that. That's the English version. So in all things, keep it calm, keep it simple, and I hope that's some help, and I'll stop and take questions.